Okay, and now we are going to turn it over to Christine. Christine, thank you. It is an honor to have you here today.
Thank you for having me. I've been lucky enough to present a few different times, but they were very specific to like prostate cancer or colorectal cancer. So this Bert asked me to be a little broader, and I absolutely wanted to do that. So my name is Christine Trumbull. I'm a pelvic floor physical therapist, and I at Trumbull Physical Therapy and work alongside three other pelvic floor physical therapists doing what we do. And so we are a bit obsessed about the pelvic floor. So we love to share all we know about it. So this is what we're gonna do tonight. Certainly, yeah, speak up if you have a question, or we can wait till after, whatever. It doesn't matter to me so much. Um, okay, so first of all, I'm not great at this, so we'll see how this goes. But okay, so we're going to talk about the pelvic floor muscle and the abdominal muscle. So again, I've talked about this very specifically to different diagnoses, but in truth, the pelvic floor and the abdominal muscles are very important for all that we do, all function that we do, whether we're able maintaining balance, whether we are strength training, whether we are trying to do like agility. And certainly, after different abdominal surgeries, these muscles need to be rehabbed and be strong. And so we're going to kind of talk about the anatomy and the physiology about that, and then just give like some specific examples. The pelvic floor muscles in general, and I'm going to show you some diagrams, but the pelvic floor muscles in general work in synergy with your abdominal muscles. If you have a weak pelvic floor, you are very likely to have weak abdominal muscles, and vice versa. The abdominal muscles also help the pelvic floor with strength. So those two things we can't separate. These muscles work in order to mitigate forces that occur. These forces can occur during mobility or outside forces. Certainly, sneezing, coughing, running, jumping, we are familiar with those. But also just getting off the floor and running up the stairs and bringing your groceries in. It doesn't matter. Any force that you apply to your body, your pelvic floor and your abdominal muscles are contracting. It also does, these muscles prevent excessive downward pressure on pelvic organs. And this includes like when people talk about like pelvic organ prolapse, the pelvic muscles are very involved in being able to control that. It also, because we have two hip muscles that also come from inside the pelvic floor, this whole area provides balance and stability, both at the pelvis, the lumbar spine, and the hips. We do have research that shows us if a weak pelvic floor does result in balance not being as functional as it should be. So it's very connected. The pelvic floor, most people know more about the pelvic floor having to do with being continent. The pelvic floor muscle manages the urethral and rectal sphincters and maintains continence of stool, gas, or urine. So it keeps to have a strong pelvic floor, you have strong sphincters. Uh, so to maintain continence. And then, of course, the pelvic floor has to also relax to allow urination and bowel movement. Sometimes people have a too strong of a pelvic floor, and that can cause constipation. So it can go the other way too. So pelvic floor muscles also enhance sensation and orgasm, support erectile not dysfunction, supports erectile function and ejaculation in males, but also facilitates vaginal contractions and blood flow during arousal for females as well. So the pelvic floor is involved with almost everything and involved in breathing, but we're not going to go through that necessarily right now. Now, If we start looking at the anatomy of this on the left side of the picture on the left, that's looking into a pelvis of a female. And you can see sort of the complicated muscles. And this is what makes these muscles so strong and so versatile is we have six muscles actually coming from inside the pelvic floor, and they're all going, their muscle fibers are all in different directions, which is why balance and stability happens with the pelvic floor, because these muscles are able to produce forces across a lot of different angles and in different positions. This the model we're looking at right now, the urethra. It actually is labeled, but the urethra is the smallest opening, the vagina, and then the anal canal or the rectal sphincter. A male pelvic floor looks exactly the same, except it does not have a vaginal opening. The right-hand side is showing more the external muscles, like we're looking at the pelvic floor from underneath, but it sort of shows that we also have this superficial group of muscles that are also involved with support of the pelvis. These muscles aren't really involved with maintaining continence. It's more sexual function and just sort of acting sort of like the rafters of a roof, trying to hold um, the pelvic floor up, give it a little bit extra help. Now we look at a side view of this. And so the female pelvis being on the left, you can see we're pretty jammed in there. The bladder in the front, and then the urethra, then the uterus sits on top of the bladder, and we have the vaginal opening, and then the rectum is in the back, or I should say, the last 6 or 7 inches of the colon would be like it's part of the sigmoid colon you're seeing, and then the distal part of the rectum. So we are packed in here, and what we have to appreciate is that anything going on with one of these organs absolutely affects the rest of it. So in situations of constipation, significant constipation, that can affect, having pressure on the vagina, but also it can put pressure on the bladder. You have a uterus that has some fibroids. That's pretty common to have pressure going to be on the bladder. As a result of that, you can actually see the bladder, like, or the fibroid, like caving the bladder in. So everything affects everybody else here. Also including like if the pelvic floor is weak, you potentially could have a weak rectal sphincter and a weak urethral sphincter and have issues with both, um, a leaking or being incontinent of both of those things. The other thing to think about, because we're kind of packed in here, is surgical surgery that has to be done. And this is regarding cancer, but there's a lot of other reasons why we have surgery. And surgery does, take a little bit of a toll on the fascia inside the abdomen. Um, but like with say radiation is become amazingly precise, unbelievable. But sometimes it does have to go through two of the organs or one of the an additional organ to get to where they want those beams to be. So sometimes we see, after colorectal radiation, the bladder is a little hyper and not acting as well as it should. Now it heals, but it's just something good to know. The radiation, I would say most of the surgeries that are done and most of the radiation is done above the pelvic floor. So we almost never see that the treatments have affected the pelvic floor strength directly. Okay. So that's important to know. They stay above. All the treatments and the surgeries typically stay above unless there's something that's involving directly a sphincter, an external sphincter. So on the right, we have a side view, same thing. Everything's kind of packed in there. You can have an enlarged prostate that affects emptying your bowels. There's just nothing in there in our not our abdomen, but at our pelvis happens in isolation. Um, the other thing that happens, which is kind of interesting with the pelvic organs, is that if something is irritated, like say from treatment, or even just you're someone that gets a lot of UTIs, or you have endometriosis, or any of those type of things, that will adversely affect the pelvic floor. It'll actually increase pelvic floor tone and cause pain. So the pelvic floor is capable of being weak and causing issues, but it's also capable of going into spasm and causing a lot of discomfort in the pelvis. And sometimes that will feel like cramping, um, burning. There's a lot of different that is one of the things about the pelvic floor. It can give you a lot of different symptoms. That's why sometimes it's hard to figure out what's happening initially. But um, so that's these. Any questions about all this? Okay. So we have the pelvic floor, and we'll talk more about the pelvic floor. However, the pelvic floor, again, works in synergy with other muscles. So um, the um, the left side is showing like we all. It's sort of known as like core stability and core strength, that type of thing. That's what people use. We don't think about it like that. We really kind of think about that we're like canisters. And the pelvic floor is the bottom of this canister, and the diaphragm is the top of the canister, and the transversus abdominal muscles, those muscles go all the way around your abdomen and into your spine. And then those little multifidi, those muscles are like 3 to 4 inch muscles, and they go from vertebra to vertebra to vertebra, and they stabilize what we call intersegmentally. They stabilize your spine. So that's our canister. The transversus muscle, you can sort of see on the picture, the muscle fibers are horizontal. They're not going like up and down like your quad does or your hamstrings do. They're horizontal. And that's the only abdominal muscle that has horizontal fibers. So the transversus muscle is the back brace that we were born with. This muscle is responsible for back stability and back health. Now, the pelvic floor muscle is important in that when the pelvic floor muscle contracts, and we'll talk about that, but when the pelvic floor muscle contracts and lifts up, because the muscle doesn't just like shut sphincters, it actually shuts the sphincters and lifts. And they've measured, like a bladder can raise 2.5 centimeters. Or I should say the pelvic floor can raise the bladder 2.5 centimeters. So it's a good lift that it does. But in the process of it lifting, it signals the transversus muscle to contract. And then the multifidi then contracts, and the diaphragm just holds position. So why this is happening, this canister, is it's setting your spine. It is making sure that your lumbar spine and thoracic spine is stable. Your abdominal organs are protected. Your pelvic floor's got those sphincters shut, and now you can add a force to your body. So something like coughing. Oh, I just saw you coughing, Carolyn. Right on cue. Thank you very much about that. So when you cough, that is a force to your body. And you can, when you have a bronchial cough, you can feel like when you cough, it does stress your abdominal wall. It stresses the muscles in your back. And if you don't have a strong pelvic floor, you're likely to leak urine with coughing or sneezing, because that is a force. It's just an internal force. But so is lifting groceries. So is reaching to pull down something out of a shelf, or picking something, being in the garage and moving stuff around. Pushing and pulling things, that all are also forces. Getting off the floor is a force. You definitely can leak urine if you're trying to get off the floor. But if your core is really weak, you're gonna just have difficulty getting off the floor because your spine can't stabilize itself. So these muscles are involved with everything that we do, everything that we do. Now, the middle picture just shows you all the other muscles that are involved. And the pelvic floor muscles also basically work with these muscles as well. And this is where the argument and the research comes from balance. Like that big muscle, that adductor, like that's a major stability balance muscle for us. And that's a muscle that we actually see often be weak. So all of these muscles in the middle here also um, when we react when the canister reacts. So the canister, these muscles, I should say too, this canister of muscles, they're like preemptive muscles. So like your body knows that you're gonna sneeze and it braces all by itself. Like sometimes we feel like we have to do a little extra bracing sometimes, but it braces as much as it needs to brace. Or I make a decision to pick up a box that looks kind of heavy. Those muscles are contracting before you lift. So these muscles very much are tied into your brain as well. And which is why these being strong also, you get this reciprocal sort of like the brain's like learns which muscles that it has to focus on. And then those muscles are strong enough to do what they're doing. And there's like a whole loop that happens. We also have all the way to the right, those muscles that you're seeing right there, those muscles actually all attach inside the pelvis. So again, besides just the pelvic floor muscle, we have three hip muscles that attach to the pelvic floor inside the pelvis. So that's like, again, where this balance and stability comes in. So we talked about this a little bit already. The stabilization of the that canister is your pelvic floor muscle. Transversus contracts, the back muscles contract, and your diaphragm just holds. Again, this happened during cardio and weight training exercises. Your pelvic floor needs to be strong. We often see injuries, like saying, like with like running injuries or um, strength training injuries, most of the time when the pelvic floor and the abdominal muscles aren't strong enough to kind of mitigate those forces. We talked about the sphincters. The other thing that the pelvic floor does is it assists, it acts like a pump, and it assists like the veins, your venous return because arteries have muscles within the wall and the heart can just pump everything through. Veins don't have that. They're pretty thin walled. So blood will just sort of pool. And we rely on our muscles, like say in your calf, those muscles are what pumps the fluid back out of your leg to make its way back up through the pelvis. But when it gets to the pelvis, that's when the pelvic floor helps send it the rest of the way back into your main venous system to go back to your heart. So though that's important, that's super important. And that's the same with lymphatic damage, or sorry, lymphatic fluid as well. So that is very important. And it also, we do sometimes can get pelvic congestion. And pelvic congestion is when, believe it or not, we do get varicose veins in our pelvis. Some of the veins that go to our uterus and bladder, they can have just like varicose veins you have in your leg. They expand and they have a really hard time getting blood out. It's not an uncommon thing. And it just makes you very uncomfortable. People that have it, they feel like they have to lay down all the time or can't stand very long. The pelvic floor muscle helps that as well. So we've talked enough about a pelvic floor contraction. So, what is a pelvic floor contraction and how do you do it? So, we have some different cues that we use, and we play with different cues to see what works. And pelvic floor physical therapy, one of the things that we can do that other therapists are not trained to do is we do internal evaluations because I can look at somebody, but I have no idea what their pelvic floor is doing. Um, and so what we do is an internal evaluation and we actually assess it. And so when we do an internal evaluation, it's nothing like an OB-GYN kind of thing. We don't have speculums, we don't have stirrups, um, just a gloved finger vaginally or rectally. It depends on why the person is there. Men, of course, we have to do rectally, and women we can do vaginally. But what we do is we have you do a contraction or whatever you think a pelvic floor contraction is, and then we can evaluate that. Um, because what we really want to have happen is that you can, um, excuse me, you can what do I want to say? Contract the muscle in isolation. So often our brain is an amazing thing. Your brain knows when your pelvic floor is weak. And so that's when you like cross your legs in order to sneeze or like you stop and then you focus and, that type of thing. So your brain will start using other muscles. Sometimes we see people using their glutes, like the big muscles, the gluteus muscles. And that does not help you. The pelvic floor needs to be able to do this by itself. So that's like a big thing that we see. And we give you verbal cues so that like when you leave the office, you know exactly what you're doing. And then we'll evaluate like sometimes people need more power, some people need more endurance, some people, believe it or not, need more agility. Like your pelvic floor needs to react because sometimes you sneeze and you didn't know it was coming. So we expect your pelvic floor muscle to be a very, very high functioning muscle because so much other stuff, if you will, and function depends on it. So some of the cues that we give is we sometimes it's just like contract your pelvic floor muscles or contract your muscles like you're trying to stop urination. That sometimes is a good cue. Sometimes it's not a good cue with people. Men are a little bit different. Their pelvic floor in the front seems to be a little bit more stronger. And of course, they don't push babies out. Their better cue is like lifting the scrotum up or just behind it and thinking about like lifting it up into your pelvis. So that's the lifting part. The other one that we use more now, we get better results, honestly. Seems weird. We get a chuckle out of our patients typically, but feeling or thinking about pulling a blueberry up your vagina and then turning it's almost like a two-part contraction, like you're pulling up but then you're thinking about cinching it. And so now you're thinking about like you're closing a drawstring bag. Garbage bag is always what I think about, which is you know, not the greatest thing to think about, but it does work. So yeah, so that's how we teach most of the time a pelvic floor contraction is doing that because it keeps it isolated and that whole cinching up that even little bit more pulling, that's where you get that urethral closure, but that's also when the transversus muscle is going to come on and you may be able to feel it there like right now if you're doing it. You feel a slight contraction of your abdominal muscles when you do the contraction, the pelvic floor contraction. So that's sort of how you do a pelvic floor contraction. And we would say, okay, so do some fast ones. How long can you hold it? Um, like any other muscle. So this is a picture that kind of shows like when you breathe and you draw your pelvic floor up, what happens is that pelvic floor lifts and the transversus muscle almost just cinches you. Like, you really want to think about that muscle? It's like a back brace. You're like just cinching it. Like if you had like a Velcro sort of back brace, if you ever had to wear one of those, or girdle maybe, I guess that too, if people wear girdles anymore. But that's what that muscle does. And then the diaphragm just is just like breathing as it should. So like you shouldn't be holding your breath because when you hold your breath, actually the pelvic floor can't raise and it pushes down and that actually causes weakness. So, um, the goal is like you should be able to do pelvic floor contractions when having a conversation and nobody knows you're contracting your pelvic floor. So like you're not like squeezing your face or you're not holding your breath or um anything like that. So that's where this canister starts to happen. But actually, let me go back to that for a second. And the pelvic floor works best with an exhale, and that is we're wired that way, but that makes sense because coughing and sneezing, all of those things are exhalations. Like if you see some of these like Olympic weightlifters that are doing like these enormous amounts of weight, they exhale and they kind of like yell as they're exhaling because your pelvic floor and your transversus, they work best with an exhalation. And that's sort of where like if sometimes people will teach like if you're doing like machines at the gym or doing stuff that whole like exhaling with exertion, that's where that came back from. So now that's kind of the anatomy. That's what your pelvic floor and your abdominal muscles, how they work and how important they are. But there's what we some of this I'm sure you've seen. But the what we see in the clinic is that we come from a situation. Sometimes we come from a situation and we get a diagnosis, and this is maybe an example. Like we get a diagnosis. Our patient gets a diagnosis of maybe rectal cancer, and they're going to have to start treatments. Uh, what we find is we like if they're starting to we'll get people sent to us after the fact like that now they're having some incontinence but it's because like this female she had like four babies and she never really got her pelvic floor back to where it was. So she's starting with a weak pelvic floor, or she's starting with a weak core. And this goes with men too. Like maybe they've already had some other like hernia repairs, which greatly affects the abdominal wall. Sometimes, we're not all like at peak fitness, strength and all this when we get a diagnosis. So so it's important to be thinking about your pelvic floor and your abdominal muscles. And we want you to be able to go into treatment um, with knowing like that you are strong and the pelvic floor, like you may not have any problem with incontinence and whatnot. Because a lot of times that's just the only example I'm using right now. But it's because we what I want to say. We have a period of our life, and there's actually really people like it's almost like a movement right now. We have a period of our life, typically like in our 35 to 45, 50, is we lead more sedentary lives because sometimes we end up with our job. Now we are sitting and we're in charge of people. And we're not running around like little kid with little kids and you're doing everything you got to be doing for your family around you and the amount of exercise and activity we do greatly drops off and we are slowly just getting weaker and not realizing it. um So that's sort of what we're combating. Now we know though, let me see if I can do this for a second. Yeah, okay. Um, okay. So we already know, I mean, the research is out there, that even like exercising during cancer treatment is effective. Um, and the things that they're seeing is reducing fatigue and nausea, improving mood, improving sleep, maintaining muscle mass, maintaining bone density. It does exercise always enhances your immune function. And then getting ready for going into recovery phase and quality of life for sure. So we see that exercise is helpful. Now, if we look at the supportive after cancer treatment, okay, we know that exercise is key. Cardiovascular, strength training, all of those things contribute to recovery. Return to what your lifestyle is. Everybody has different goals. Um, and long-term survival just by just increasing your cardiovascular health, nutrition, strength, an increase in general activity level in general, basically. So we know all that. Like we know that all of those things are good. But I will say what happens is sometimes people sort of fall off doing it or can't do it because they have a back problem, because their core is work, or their core is weak, or they are like leaking urine when they're trying to get back to, doing Zumba or trying to like doing a running program and then they start falling back off of it. And it's important to us that we are preparing people to be strong so that you can get back to doing what you want to do and maybe do a bunch of stuff you haven't been doing because you've had to sit at a desk for hours and hours and days and years and all that. So, what we want to do a little more of and is prehabilitation and orthopedics, cardiology. They've been doing this for years. Like if you have a total knee, if anybody's had one, you go to PT for 8 weeks beforehand. Cardio surgeries, you are going and doing a bunch of stuff to make sure you're ready for that surgery. We see prostate cancers, they usually will come in for prehab. That's a mix. Like 50% of surgeons say yes, go do it, or or they don't do it. But one of the things that was difficult is we were getting people to start like knowing what Kegels were and how to do Kegels like 10 days before their surgery. Now we can do that, and so that they know what they're going to do post cancer, the post treatment. But it would have been nice to have like maybe 3 or 4 weeks. So what we know is all prehab when the orthopedics and cardiology have been studied the most, and there is some research with 6 weeks of rehab before prostate cancer, but that's it. That's all we have for research. And what we know is there definitely the surgeries have better outcomes. Now, depending on what it is, what's the outcome? I'm not sure. Shorter hospital stays, definitely improved psychological readiness for the surgery. And there's a term of called frailty where it decreases frailty. And frailty, this is a general word, but the definition is where the person shows some weakness or persistent fatigue or just like slow movement in general, like not sure of their balance, not sure of their stability. Um, they have numbers where taking somebody that is already presenting that way, the outcomes aren't great. The hospital stays are longer. So that is another reason why we want to have like prehab happening in multiple arenas, not just orthopedics and cardiology and prostate cancer. So Prehabilitation, it would be sort of an ideal world. Of course, there's a diagnosis, and then we look at sort of what are the complications, and then we deal with knowing that you are going to definitely have the ability to exercise during treatment, and you're going to have the ability to exercise after treatment. Um, but can we get you ready to do all that first? So it's especially valuable, yeah, for older adults. Definition of older is like 4 decades, but older adults are those with comorbidities. So maybe you already had like a total knee replacement and you've really kind of not been exercising as much as you used to. And we know that when you are sitting, your pelvic floor and your abdominal muscles are off. They're not doing anything until you stand up. Once you stand up and go against gravity, the muscles start contracting. So if you have other comorbidities that have taken you out of being able to do a lot of exercise, then your pelvic floor and your abdominal wall is going to be weak. Certainly C-sections, vaginal deliveries, abdominal surgeries, hernia repair, anything. There's so many things. And if you've had other major surgeries, there's a big correlation between abdominal surgeries and back pain within like 3 years if you don't get your abdominal muscles back. So that is why we, are obsessed about the pelvic floor and the abdominal wall and this whole unit, because it sets you up to be able to exercise like all the way through. Now, the exercises, depending on what, obviously that everything can be different amongst each person, but everybody needs a strong pelvic floor. Everybody needs a strong abdominal wall to function. And now there's quite a bit of research coming out with we're not lifting heavy enough weights. And that's not really controversial anymore. That is definitely, they've done some nice studies of 75 and over. And there are differences in balance, improvements in balance, improvements in stability, improvements in walking speed. So it's not it's your whole lifespan. Um, these muscles need to be strong so that you can now go the next step and actually strengthening. And because you can't lift heavy weights if your pelvic floor and your abdominal wall, excuse me, aren't going to set your spine well enough. That's how you're going to get injured, um, with your hip and your back or whatever. Okay. This thing keeps wanting to move on me. So that is, I think, nope, that's wrong. I got one more. What I'm trying to do though is, whoop, did it again. Okay. Anyways, so it offers a proactive approach, and meeting the person where they're at, like evaluating strength, evaluating, what's going on. What activities do they do now they want to get back to? What activities might they want to get better at? Um, Everybody's very, very different. But what we do know, and again, these are like post-interview type studies, if you will, but it does build, exercise builds physical and emotional resilience. And that is something you want to do before you go into treatment for sure. It does support each person's baseline because, again, everybody is coming from a different physical condition when a diagnosis is made. It does empower the patient. We believe, to take an active role in their care. To have something that you can control. Great. And it does enhance neuromuscular coordination. They're just seeing this awesome like exercise relationship to your brain. A lot of that with Parkinson's, the effects of exercise. Um, it really is what we have to remember is it's the nerves that tell the muscles what to do and when to do it and the timing of it and who turns on and who turns off. So exercise is really a neural thing. And we know that exercise, including strength training, is showing an increases in neuroplasticity that, will increase, it increases like balance. If you get unstable, if you trip over something, if you've been exercising and preparing basically for something like that, your reaction time is going to be better. You can get your hands out in front of you, or you can catch your balance, gait, posture, coordination, all of those things. And again, it does help with protection for your brain as well, because the muscles are going to adapt to whatever you're training, whatever muscles. So you do really want to think about exercise as being not just about your heart and not being just about your muscles. It's very much about your brain as well. Um, yeah, and we see yeah, what do I want to say? We just see what happens when people are go into treatments, not at their you don't have to be at peak physical health, but you want to have some control over it and get ready. Because a lot of pelvic floor stuff, you can get strong in your pelvic floor really, really quickly. You just got to know how to do it and how to activate the muscles properly. So that is our obsession with the pelvic floor. And that's all I have. If anybody has any questions, I can get out of this. Mm, 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 mm. I don't know where to stop share. Oh, am I on? Oh, a jewelry drawstring bag. I like that. That's a good one. That's way better than a garbage bag. Way better.
Christine, thank you so much. This is very helpful to know the anatomy and how things are supporting basically us being able to stand upright and do so much. I for breast cancer, I had 5 years of an estradiol, which is a anti-estrogen inhibitor, right?
Mhm.
And so I'm I'm wondering, I think I've noticed sort of aging more in my exterior skin, etc. I'm wondering how is it or potentially affecting the abdominal wall and muscles and you know those structures internally.
Okay, so we do know that as de estrogen decreases, we do lose strength. Like the muscle fibers do lose power. And that is a big deal. And the other thing that estrogen decreases is what do I want to say? The strength, like the tensile strength of your tendons and your
Mhm.
ligaments. So we know that happens because we start seeing like more overuse injuries, uh, yeah, some more overuse injuries like perimenopausal, postmenopausal. It's like when you have that year, you feel like your whole body just fell apart for no reason. Like that's the year
Mhm.
that starts to happen. So, but that doesn't that but that makes strengthening more important,
Mhm.
because we know that estrogen decreases muscle strength, and we know that it does affect like micro sort of in a micro way tendons, ligaments, but that doesn't mean you don't exercise.
Right.
Let's just say that because you actually that's a reason to have the muscles more reactive and stronger. Does it affect the pelvic floor? Definitely gets affected. I mean the vagina specifically. Definitely moisturizer, a lot of moisturizer because the estrogen's not there. Um, so we do a lot of that. But the pelvic floor muscle itself, it's getting weaker, but not it doesn't even have to be just because of the estrogen.
Mhm.
if we're not aware of what the pelvic floor should be doing, it can just get a little weak on its own.
Mhm.
So yeah. Yeah, so that's where this push is, and this is where I should probably be more specific. This push is we're seeing women going into perimenopause and menopause weak, and that's a problem because now, like now your doctor tells you
Mhm.
now you got to go do all this exercise, and try to catch up because what's happening is women, I'm going to speak to women mostly, is that like once there's a number, it's like 62% of women don't return after childbirth to their previous activity level or exercise because they're leaking urine.
Mhm.
But that happens like in your 30s, like that you start, or and so then you end up like not wanting to exercise. Probably that's the number one thing people come to us is like, I'm trying to run, I'm trying to get back into exercise, and I'm leaking all the time. I can't do a jumping jack, or I can't do those things. And we're like, yay, we're glad you're here because you have to exercise. But there really is this movement towards we're right now we're like telling our 35-year-olds and our 42-year-olds, and you can't let exercise go because the long-term effect of that is not good.
Yeah.
You'd rather come into menopause with like good muscle tone and strong, bones and the whole thing. But there's definitely there, some people are calling it almost like a crisis kind of mode thing we're on, but we crawl, everything's a crisis. But for women, that age group, that age where you end up at a desk job, and you don't feel comfortable either because of pain or incontinence, you really get weak, really, really.
Mhm. Yeah.
Yeah.
Quick follow-up. I did have a couple of hernias.
Hmm.
And so you talked about something hernias affecting the abdominal wall. Is that?
Yeah, so surgical hernias, every surgeon has a different way they do it, and technology is changing. But usually they use part of the abdominal wall to correct it. They used to like use the internal oblique. Um, but sometimes there's pain left over from the hernia. And when in the presence of pain, muscles don't want to contract very hard in the presence of pain. They become somewhat inhibited. So our thought with hernias is we just want to make sure that that either is not happening or like it didn't happen.
Mhm.
Um, and hernias like also like umbilical hernias, and then like when you have a baby, you can have a diastasis, like an opening up of the rectus muscle. Those things, yeah, have to be rehabbed. Have to be
Mhm.
rehabbed. Yeah, abdominal surgeons don't think about physical therapy usually. But we end up with people that tried to do something else and couldn't. So it would be more just like evaluating, your strength, and is your abdominal muscles working the way they
Mhm.
should? Can we give you different strategies? Is there a different way to do things that you can strengthen? Yeah.
Yeah, and I am a fan of exercise, and it's just amazing how it has helped me with balance and agility, etc. So just
It's
really,
awesome. It's
yeah,
huge,
super.
huge. I guess I will say, uh, as far as like access to pelvic floor therapy, sometimes we just get people that want to come in and just see what their pelvic floor is doing. Is it doing what it should be doing? Can I learn to use my abdominal wall better? That type of thing. And we can do it. I mean, we can, all we have to do is put a code on it, that your insurance will
Mhm.
pay for. You
Mhm.
don't have to have something wrong with you. Let me just say that. You don't have to have something wrong. You could just come and say, Can you just tell me like what my pelvis is doing, or is there something I should be doing differently, or whatever you're here for one visit, we tell you what you should be doing and you leave and maybe you never come back. So we'd much rather have people walking around with a really strong pelvic floor.
Yes.
I think what else? Yeah. Yep. So relaxing a pelvic floor exercises. It's always a challenge. Well, it depends. So if you have high tone pelvic floor, that's like if we evaluate and the muscles are sore, or feel crampy or that kind of thing, honestly, the first thing we have you do is start sitting on a tennis ball. Um, because I happen to have a pelvis here. Um, uh, so the pelvic, oop, I have to get in a certain, not sure how to do that. All right. So anyways, the red here is the pelvic floor, and the pelvic floor muscle attaches to this bony rim that doesn't move. So in the case of our non-relaxing pelvic floor, this pelvic floor has no mechanism to like stretch itself out. So we do it all the time. If your neck is feels tight, your hamstrings feel tight, you just stretch them, you move around constantly. The pelvic floor has no ability to do that. There's no mechanism for that. So even though there's like three hip muscles that come from inside the pelvic floor, you could stretch your hips up, it's still not going to touch the pelvic floor. Some fascia, but not the pelvic floor. So what we do with the pelvic floor to get it to be able to massage it out is what did I do with my tennis ball? Oh, we actually have people, how do I do this thing? Maybe I don't know how to shut that off. Anyways, can you see? Okay, there. So you sit on a tennis ball, just like right next to the rectum. And so not on the rectum, but definitely not on your sit bone. Okay, but that space in between, and you just find a sore spot, you just sit on it and just let the muscle release. Because what you're doing is pushing up into the muscle, forcing the muscle to have to relax over the tennis ball. Okay. And that's how we get it to kind of massage it out and relax it. That works for a lot of people. It actually works really well. It's just got like rolling anything, and people roll out their quads and do this. So you're just rolling out your pelvic floor with a tennis ball. That is probably but then there's also like deep breathing exercises, because when you fully inhale, you take a really deep inhale, your diaphragm drops down so that your lung expands. But because neurologically, the pelvic floor and the diaphragm are sort of related, as the diaphragm drops down, the pelvic floor relaxes. Okay. Versus like if you exhale really hard, the diaphragm goes up to push the air out, and the pelvic floor goes up as well. So they mirror each other. So deep breathing is also helps relaxing the pelvic floor. And then sometimes just trying to find the cause of it. The pelvic floor often just reacts to what's going on around it. And it can be anything. It can be emotional, it can be physical, it can be some sort of inflammation and one of the like your like people like colitis and Crohn's and that kind of thing. All right. Well, you're welcome. We will talk about the pelvic floor. You might see our act. We're in the Y all the time. We're at church groups. We go wherever. Wherever anybody wants to talk about it, we go. We love it.
Does anyone else have any more questions that they don't want recorded at this time?
There's a question in the chat from Molly.
You're gonna have to read it to me. I don't know. I don't know how to look
Says,
at.
how quickly can you strengthen your pelvic floor? And what kind of routine do you suggest?
Sure. Thank you. Great question. It's more about neuromotor, right? So the first you can actually definition of strength. Definition of strength is like hypertrophy sort of muscle cells. But how we get to that point is we need a better activation of your pelvic floor, which is the nerve. So um, you get stronger actually sometimes within, it just sounds crazy, but a couple days. But that's only the neuromotor part. That's just because your nerves figured out what you wanted them to do because they weren't sure what you wanted them to do. So then when you start practicing it, the timing of the nerve and the muscle is getting better. And then as you like that cinching up thing, the other reason why we do that is because as you're trying to like cinch it, what's happening is the nerves are looking for more muscle cells to recruit. And then the more muscle cells that get recruited, that's how your strength goes up. So it happens like right from the beginning that this whole strengthening process happens. Now, true hypertrophy, like if you want better biceps or that kind of thing, that can take, so they say, somewhere like around, gosh, 12, 16 weeks. But that, I mean, your pelvic floor can max out before that because it's not made to like really just hypertrophy because that's not great for the pelvic floor. That creates different dysfunction. So right away, right away. And what would we have you do normally? So we make sure that you're doing it correctly. And then you want to do about 30 repetitions a day of pelvic floor contractions total. But what you're going to do is you're going to do like some 5-second holds. You're going to do some 10-second holds for the endurance. But then you're going to also do these quick contractions for like sort of the agility component of the muscle. And you'll just do maybe 5 to 10 of those so that ultimately it adds up to 30 or more because that's the research we have to to um uh to get like a really good neuromuscular re-education response is about 30 repetitions a day. Whether you're learning scales on a piano or learning some other, you're juggling. Like it doesn't matter. Like your nerves and muscles need some repetition, repetition, repetition. So that's usually what we do. Is that would be, we might differ a little bit between the four of us, but not that much. But what I will say, what we know is that that's how we just get your pelvic floor strong. Okay. So that's like a 5 out of 5. We would grade that. To get it beyond that and to get it to be reactive and more functional for you, lifting weights, adding weight to your body because your pelvic floor has to meet that downward force. So actually lifting weights and just exercising and doing machines and all those, things, running, all of those things, your pelvic floor has to respond to that. So you're strengthening your pelvic floor every time you do bicep curls. Um, and then, now with this, people are moving towards heavier weights, same thing. The pelvic floor gets stronger and more reactive or quicker. So every day you should be doing pelvic floor contractions because you need them forever. So just get in the habit of like, okay, I'm going to brushing your teeth. If you're doing your balance, you can stand on one leg and do Kegels if you want, or you can go in every time you go in the shower, do 10 Kegels. Every time you get in the car, do 5. Just have like something that is keyed in that you have to do every day anyways. Um, is the way to do it. You need to, this exercise. I mean, it needs to just be strong always. Did I answer the question? But all activity is good. The thing that's not good for the pelvic floor is sitting, a lot of sitting. Um, but this is where it gets frustrating because at some point people have mobility issues, and they can't get up or they think they can't get up and do anything. Yeah. So that's why it's like now there's a big push. We gotta be exercising and doing weightlifting like all through life. They do have, I should say, they do have a recommendation with the lifting. Is that you should be doing 60 minutes of lifting ideally, um, every week. So, and this is a little bit more of the heavier lifting stuff that's another topic. But and then cardiovascular, that moves around a little bit at like 120 minutes a week to 150 minutes a week. But they're just really seeing that it's both. It's both. It's not, we've really geared ourselves towards cardiovascular in the last few decades, like do everything for your heart, but we didn't really talk anything about our muscles very much. And now we know like the muscles and that whole neural brain connection to our muscles is become huge, huge. So both things you should be doing. Downsize to adjustable standing desk for computer work and Zooms. Yeah. Are there downsides to adjustable standing desks? Downsize. I mean, you can't stand all day. I mean, we're basically our body was made to either walk or squat on the ground to defecate. That's it. Like we were never made to sit in a chair. We were never made to stand still. So standing has a leg up a little bit on sitting, because at least standing, your pelvic floor is on, your core is on, your legs are doing something. Sitting is definitely worse, but you can't stand all day either. So to have the ability to do both is better. Um, there's walking pads now with standing desks, and there's oh my God, there's so much stuff like standing on balance stuff. I mean, none of that stuff is wrong. But it's just like when you start to fatigue, then sit for a little while. But sitting all day, yeah, it's not good because everything shuts off. We have like all the proof in the world. The pelvic floor is basically off. So you can just gradually be getting weaker just sitting there, unfortunately. So
Well, looks like we barely have any more questions.
all righty, great.
And thank you so much. It was very comforting to know that I don't have an issue. Um,
We'll find an issue.
yeah. But it was very like this was so educational because there's things that I wish I knew beforehand that I don't know like that I know now. So it's like really awesome. So I really appreciate you coming and doing this Zoom for us tonight.
You're very welcome. We love doing it. We love doing it. So yeah, feel free to come in. We'll tell you what your pelvic floor is doing. We'll be brutally honest.
What's the address?
I'm downstairs from you.
Oh, I should
I'm
know
like,
that, right?
right now I'm downstairs.
Oh my goodness. I'll come see you guys tomorrow
Okay.
because I need help.
All
Yeah,
right, well
I'm
then come
the first to
down.
tell you.
Come
But
down.
thank you so much. This honestly, this was so informational and I really appreciate it. And I can't wait to make my appointment.
Excellent.
But
Excellent.
thank you so much.
You're welcome. All right. Goodbye, everybody.
Good night, everyone. You
Bye.
guys, thank you for joining. You guys all have a great night and we'll see you guys again. Thank you.
Bye.
Bye bye.